I will repeat. The electrocardiogram is the representation of the electrical events of the heart during a cardiac cycle. It is the graphical recording of the electrical activity of the heart. Now let me explain in briefly about the anatomy and physiology of heart. We all know that ECG is the record of electrical activity of the heart. Normally, the electrical activity precedes the mechanical activity of the heart. In the heart, both the atria and ventricles have separate electrical activity. The electrical activity has two phases, phase of depolarization and phase of repolarization. Depolarization is the spread of stimulus through the heart muscle, whereas repolarization is the return of the stimulated heart muscle to the resting state. That means during the depolarization, the heart muscle undergoes contraction, whereas in the phase of repolarization, the contracted muscle comes back or return to its resting state. The wave of depolarization spreads from the endocardium to the epicardium, whereas the repolarization wave spreads from the epicardium to the endocardium. So, what is depolarization? As I told you, any contraction of the muscle is associated with the electrical changes that is known as depolarization. These changes that occurs during the contraction of the cardiac muscles, whether atria or the ventricle, can be detected by the electrodes when they are attached to the surface of the body. So coming to the repolarization, it is the phase of recovery or relaxation. Compared to the depolarization, the phase of recovery is a slow process. It lasts about 100 milliseconds or longer, but the difference between the repolarization and the depolarization is the repolarization occurs simultaneously over the extensive portions of the fiber. Let us know about the pacemakers of the heart. The heart has got a natural pacemaker known as sinoatrial node, that is SA node, which generates the electrical signals that causes the heart chambers to contract and pump the blood. The SA node is known as the dominant pacemaker with an intrinsic rate of 60 to 100 beats per minute. AV node is the next backup pacemaker with an intrinsic rate of 40 to 60 beats per minute. Even the ventricular cells can also generate the electrical signals with an intrinsic rate of 20 to 40 beats per minute. This is the conduction system of the heart. You can see the SA node, AV node, bundle of His, left bundle branch, right bundle branch. These two, right and the left bundle branch, terminates as the Purkinje fibers. In addition to the right bundle branch. The left bundle branch is further divided into posterior-inferior fascicle of the left bundle branch and antero-superior fascicle.
ನೆಟ್ವರ್ಕ್ ಪ್ರಾಬ್ಲಮ್ ಬರ್ತಾ ಇದೆ ಸರ್, ನೆಟ್ವರ್ಕ್ ಪ್ರಾಬ್ಲಮ್ ಬರ್ತಾ ಇದೆ, ಕಟ್ ಆಗ್ತಿದೆ ವಾಯ್ಸ್. ಹಲೋ
Hello. Are we audible now?
Should I repeat the conducting system?
ನೋ ಮೇಡಮ್.
Okay.
So when the electrical impulses are generated at the AV node, it passes through the internodal pathways. These are the three internodal pathways which transmits the flow of impulses to the right atrium and the left atrium. From the SA node, through the internodal pathways, the electrical impulses or the cardiac impulses are transmitted to the AV node. From the AV node, it is transmitted to the bundle of His. From the bundle of His, through the left bundle branch block and the right bundle branch block, it transmits the impulses through the Purkinje fibers to the right ventricle and the left ventricle.
Requesting the participants to expand your screen.
Coming to the few basic laws of ECG. The positive deflection appears in any lead if the wave of depolarization spreads towards the positive pole of that lead, whereas the negative deflection appears if the wave of depolarization spreads away from the positive pole of that lead. And biphasic deflection appears if the mean depolarization path is directed at right angles to any lead. We all know that ECG has standard 12 leads. There are 3 standard limb leads, 3 augmented limb leads or unipolar limb leads, and 6 precardial leads. Let us know in detail about the standard limb leads, augmented limb leads, and the precardial limb leads. This 12 lead ECG provides the information about the heart's electric activity in the 3 orthogonal directions, that is right to left, superior to inferior, and anterior to posterior. So coming to the ECG leads, which measures the difference in the electrical potential between 2 points. Coming to the bipolar leads, in the bipolar leads, that is lead 1, lead 2, lead 3, has 2 different points on the body, whereas the unipolar leads such as AVR, AVL, and AVF has 1 point on the body, and there will be a virtual reference point with the 0 electrical potential. I'm telling you here, this with the 0 electrical potential located in the center of the heart. Let me show the diagrammatic picture. This is the standard limb lead showing the lead 1, lead 2, and the lead 3. Lead 1 is between right arm and the left arm. Lead 2 is between right arm and the left leg. And the lead 3 is between left arm and the left leg. How you have to record the ECG? In case of standard limb leads such as lead 1, lead 2, and lead 3, which are bipolar limb leads, requires 2 sensors that are attached to the skin to make a lead. If one connects the line between the 2 sensors for making a lead, one will become the vector. There will be in case of bipolar standard leads such as lead 1, lead 2, lead 3, there will be one positive end at one electrode and a negative at the other electrode. The positioning of the leads, this is what I have showed you. This positioning of the leads, lead 1, lead 2 and lead 3 has created a triangle. This positioning of the leads were first given by Enthoven. Hence, this triangle is known as the Enthoven's triangle. So you can see the placement of the bipolar leads. In the lead 1, it is right arm and left arm. This is the like a graphical representation. And lead 2 is right arm to the left leg. And lead 3 is left arm to the left leg. Coming to the placement of unipolar limb leads, I have already told you that in case of unipolar limb leads, that is AVR, AVL and AVF, which measures the electrical activity at one point on the body, that is on of the heart, with a virtual reference point with zero electrical potential located in the center of the heart. So this point is unipolar limb leads has one point, that is right arm, and with the center of the heart creates AVR, and the left arm and the center of the heart creates lead AVL, and the AVF is between the left foot and the center of the heart. Here this A indicates augmentation. What I mean by augmentation? It is the process of making or becoming greater in size. So in this slide, you can see the lead 1, lead 2, lead 3, AVR, AVL and AVF with the different electrical activities. So, coming to the precardial leads, there are 6 precardial leads: V1, V2, V3, V4, V5 and V6. These precardial leads have the positive electrode which is placed on the chest in the different position. These leads record the electrical changes of the heart in the cross-sectional plane. So, I am showing the picture of the cross-sectional plane of the heart where V1 and V2 represent septum, V3 and V4 represents anterior, and V5 and V6 represents the lateral wall of the heart. See, this is the angle of Lewis. This is the mid-clavicular line. This is the mid-axillary line where you have to place the precardial leads. This is how you have to place the precardial leads. That is the chest leads. That is the electrodes placed on the chest. V1 electrode should be placed in the 4th right intercostal space, immediately right to the sternum, and V2 electrode should be placed in the 4th intercostal space, immediately left to the sternum. V3 electrode should be placed between V2 and V4. V4, this is the main important electrode that has to be placed in the 5th intercostal space in the mid-clavicular line. You can see the mid-clavicular line. In the 5th intercostal space, you have to place the V4 electrode. And the V3 is between V2 and V4. Where you have to place the V5 lead? In the same horizontal plane, that is in the fifth intercostal space, but in the anterior axillary line, but in the same space, that is fifth intercostal space. Coming to the V6 electrode, you have to place the electrode in the same plane, that is fifth intercostal space, but in the mid-axillary line. This is the mid-axillary line. This is the slide showing how and where you have to place the precardial leads such as V1, V2, V3, V4, V5 and V6. In a normal ECG, the arrangement of leads will be like this. First will be lead 1, that is the bipolar leads such as lead 1, lead 2, lead 3. Then comes the unipolar limb leads AVR, AVR, AVF, and the precardial leads V1, V2, V3 and V4, V5, V6. Why electrocardiogram is very useful? Electrocardiogram is used as the gold standard to time the various events in the cardiac cycle. This ECG is used continuously for the monitoring of the patients in the intensive care units and in the operation theatres during the surgical procedure, where you require a continuous monitoring of the heart, that is by the ECG. Coming to the other uses of ECG, we require ECG to diagnose ischemia. Especially most important is during the changes occurs during the myocardial infarction, and also to diagnose the chamber hypertrophy. It could be right ventricular hypertrophy, left ventricular hypertrophy, any sort of hypertrophies, different types of hypertrophies, and to recognize arrhythmias, that is tachyarrhythmias and bradyarrhythmias, to diagnose the miscellaneous conditions like electrolyte imbalance, especially in presence of hyperkalemia and hypokalemia, and different types of channelopathies, that is heart blocks and WPW syndrome. I will be explaining all these things, the ECG abnormal changes in the next session. Okay, and also in certain heart diseases have classical ECG pattern so that it will be easy for you to diagnose the underlying cardiac issues. So what are the indications for ECG? ECG is an important investigating tool for patients presenting with the complaints of, or patients presenting with the complaint with the history of chest pain, history of chest pain, syncope, giddiness, palpitations, seizures, history of poisoning, history of sweating, especially during night times or following heavy exercise, and tachycardia, bradycardia, hypotension, and any other problems, common problems which are occurring repeatedly, and also most of these symptoms may disappear or will occur minimally in the patients with associated with comorbidities like diabetes, hypertension. So whenever the patient comes with the history of certain complaints like chest pain or the syncope, it is always better to go for the ECG examination, ECG investigation. When you are recording an ECG, you have to follow certain technical aspects in order to minimize the artifacts. Like you should keep the electrodes in effective contact between the skin and the electrodes. That is, there should be an effective contact between the skin and the electrodes. And the calibration should be 1 millivolts is equal to 100 millimeters. And the ECG paper speed should be 25 millimeters per second. These are all required to minimize the artifacts. And patient should be placed in the supine position. Now let us see how the ECG paper looks and what it contains. So horizontally, the ECG in the ECG paper, horizontal plane, this is the horizontal axis, represents the time, whereas the vertical axis represents the amplitude. In this ECG paper, you can see the large box or big box and small box. Each large box has around 5 horizontal and 5 vertical small boxes. Okay, so this each small box is 0.04 seconds horizontally, that is the time, and each large box represents the duration of 0.2 seconds horizontally and 0.5 millivolts in the amplitude. You got it, no? So each small square is 0.04 second and each large box, this is the large box, is 0.2 seconds. Whereas the vertically, one large box represents 0.5 millivolts. What are the descriptive terms are used in the electrocardiogram? I want to announce one thing. If you have any doubts, we can discuss at the end of the session. So what are the descriptive terms that are used in the electrocardiogram? ECG has waves, segments, intervals, and the complex. So let us see what are the waves, what are the intervals, and what are the segments. This is the normal ECG showing P wave, QRS complex, ST segment, T wave, U wave, QT interval from here to here, QT interval, and PR interval and QRS interval. I'm going to explain you each wave and the interval and the segment in detail. So the first positive wave is the P wave. P wave is the sequential activation, that is the depolarization of both left and the right atria. Whereas the QRS complex, this is the QRS complex, is the ventricular depolarization, that is both right and the left ventricular depolarization. Normally, the ventricles are activated simultaneously. This is the U wave and this is the T wave. What is STT wave? This is the T wave. This is the ventricular depolarization. This ST segment, I'm going to explain you later. This is the plateau phase of repolarization of the ventricles. Coming to U wave is normally not seen, but probably it may represent the ventricular repolarization. Coming to the ECG intervals, PR interval is the time interval from the onset of atrial depolarization to the onset of ventricular depolarization, that is QRS complex. This QRS duration, that is QRS interval, is the duration of the ventricular muscle depolarization. This is the QT interval, starting of the QRS complex to the end of the T wave. This is the duration of ventricular depolarization plus ventricular repolarization. What is RR interval? This RR interval indicates the duration of ventricle cycle from one R wave to the other R wave of the QRST complex. What is PP interval? We all know that this P wave denotes the atrial, that is right atrial and the left atrial depolarization. So, it indicates the duration of atrial cycle. What is ST junction? It is known as the J point. This J point is the point where this QRS complex ends and the ST segment begins. This ST segment is the interval between the J point to the onset of T wave. This ST segment denotes the plateau phase of T wave, that is ventricular repolarization. So, this is the slide or the ECG showing all the waveforms and intervals. See, in the earlier slide, I could not show you the RR interval. This is the RR interval between the R wave of one PQRST complex and the other PQRST complex. This is the ST segment. This is the ST interval. This is the QT interval. This is the QRS duration. This is the PR interval, P wave, PR segment, ST segment. So now let us know how we have to interpret an ECG. The more you see, the more you know. So repeated interpretation and repeated interpretation helps you to identify the early abnormal changes. So, this is the normal ECG showing the standard 12 lead ECG. When you obtain an ECG, first read the patient's details, that is name of the patient, age and other details about the patient. Act confidently and then go through the ECG for the interpretation in a stepwise orderly manner. Some of the ECG machines that are recently newer machines comes with the interpretation software. Please do not totally trust this software. So, how you have to interpret an ECG? Whenever you receive an ECG, you have to interpret the ECG in an orderly manner. Like, first you have to check the rate of the heart, that is heart rate. Check for rhythm, whether regular rhythm or irregular rhythm. Check for the axis, whether the QRS, that is the cardiac axis, that is QRS axis, whether it is in normal axis or right axis deviation or left axis deviation, and look for the normal P waves, look for the PR interval and check the duration of the PR interval. see the shape and duration of the QRS complex, duration of the ST segment, and look for the T wave changes in the shape and the duration and its amplitude and the speed. And you also have to look for the U wave and duration of the QT interval. First thing, when you take an ECG in your hand, you have to start the interpretation by looking for whether the standardization is normal, regular, and it is same for all the standard 12 ECG leads. This is the standardization for picture which you will be seeing in front of all the leads in the ECG. So what does this standardization denotes? This standardization denotes whether the ECG has been taken in the properly amplitude and with the proper amplitude and with the proper speed. Normally, the vertical mark is seen at the top end of this graph. I will show you the graph. See, this is the upper level of the vertical amplitude. Normal amplitude is 10 millimeters per millivolt. That is 2 large boxes. Half amplitude is 5 millimeters per millivoltage. That is 1 large box. Double amplitude is 20 millimeter per millivolt. I have told you the standard calibration, that is 25 millimeters per second is the time, and amplitude is 0.1 millivolt per millimeter. So whenever you check the ECG, look for the vertical mark. That is it should be the normal. That is 2 big squares on the graph. It looks like this. What will happen if the amplitude of standardization is half? Then your ECG graphical representation will come as the smaller, and your measurements like QT interval, durations of the QT interval or PR interval or T wave, everything will become abnormal. What will happen when the amplitude of the standardization is double than the normal? Again, here the ECG, that is the QRS, PQRS, T complexes will become larger, and again it will give you the abnormal values. So always your standardization of the ECG paper, that is the amplitude scale, should be normal amplitude, that is 2 large squares or 2 big squares. Let us now know how to calculate the heart rate. There are 2 methods available for calculating the heart rate. Rule of 300 or rule of 1500. This is particularly used when there is a regular rhythm. And the second method is 10-second rule. This method is used when there is irregular rhythm. In the rule of 300, you have to count the number of large boxes or big boxes between the RR wave, between the RR, that is the RR interval, or QRS complex of the 2 complexes. Okay, this is the RR interval. you have to count number of big squares in the RR interval. Here 1, 2, 3, 4, 5 and this one adds up to 6. So here the heart rate is 300 divided by 6 is equal to 50 beats per minute. When you count, when you use 1500 as the numerator, then you have to count the number of small boxes. Okay, then you will get the 1500 divided by number of small boxes for the regular rhythms. The second method is 10-second rule. This 10-second rule method is used when there is irregular rhythms. That is, the RR interval varies between the PQRS complexes. So, in this method, this is an irregular rhythm. In this method, you have to count the number of beats present in the ECG during 10 seconds. That is 50 big squares. So, here you have to count 50 big squares. Usually, the ECG paper has 50 big squares. And this big squares is multiplied by 6. Then you will get the heart rate. That is, here there are 33 large boxes. So you are multiplying the 33 into 6. It will give you 198 beats per minute. Here you can see this one is the irregular rhythm. Now let us know what is the rhythm. This rhythm strip is usually present in a standard 12-lead lead at the bottom. So, evaluate the rhythm strip at the bottom of the 12-lead ECG. For what all you have to see in this rhythm strip? You have to see whether the PR interval is regular. That is, whether the rhythm is regular or irregular. Is there P wave before every QRS complex? Because sometimes, especially in atrial fibrillation, there will be absence of P wave with the irregular rhythm. So, you have to see for the P wave whether it is present before every QRS complex. And also look for any abnormal beats like atrial beats, like premature ventricular beats, premature atrial beats. All these abnormal beats are how to identify the abnormal waves. Tomorrow in the next session, I will be explaining you in detail. Today, I am explaining you only the normal, how to interpret and how to identify the normal indicators of the heart ECG. So, now we will go for the axis, that is cardiac axis. This cardiac axis or the QRS axis represents the, I will show you the next one. This cardiac axis or the QRS axis represents the direction of the electrical activity of the heart, specifically the direction of ventricular depolarization. These are the ventricles, right ventricle and the left ventricle. Here you can see the ventricles in this poster. These are in this direction, which shows the ventricular depolarization, that is between minus 30 to minus plus 90 degrees centigrade. 90 degree. This shows the normal range. What is the right axis deviation? When the direction of the ventricular depolarization is between 90 to 180, it is right axis deviation. when it is between -30 to -90, it is left axis deviation. So this QRS axis is better seen in the lead 1, lead 2, lead 3 and the AVF, where these QRS axis are positive. This suggests that axis is in the normal range. There are various methods for the ECG axis interpretation. The most commonly used method is the quadrant method. In this quadrant method, you have to look further in the lead 1 and AVF. In these two leads, when the R wave, this is the R wave, is larger than S wave, it is positive. If the R wave and S wave are equal, then it is equiphasic. If the R wave is smaller than the S wave, it is negative. So, how you have to interpret whether it is normal axis or left axis deviation or the right axis deviation? Here is the quadrant method. In the normal axis, the lead 1 and in the lead AVF, R wave is larger than S wave. So it is positive, positive, and it is between 0 to 90 or -30 to +90. In the possibility of left axis deviation, in the lead 1, R wave is, I have told you already that if the R wave is larger than S wave, it is positive. If the R wave is smaller than S wave, it is negative. So, in the left axis deviation, in the lead 1, R wave is larger than S wave, but in the AVF, R wave is smaller than the S wave. In RAD, the opposite will occur. That is, in lead 1, R wave is smaller than the S wave, whereas in the lead AVF, R wave is larger than the S wave. That is, the quadrant is +90 to +180. Coming to the P wave, this is the P wave. It is always positive in the lead 1 and lead 2. I have already told you that this P wave represents the right and the left atrial depolarization. And it is the first positive deflection in the ECG. It is always negative in the AVR. These are all the normal P waves. I'm telling you how the normal P wave looks. This P wave duration should be always less than normal P wave have a duration of less than 3 small squares. That is this duration starting of the P wave to the end of the P wave, which represents the right and the left atrial depolarization, is 0.12 seconds. Whereas the amplitude, that is the vertical axis, it should be less than 2.5 small squares. You can see here 1, 2 and half. So this is less than 2.5 squares, that is 2.5 millimeters per millivolt, that is in the amplitude. It is this P wave is biphasic in lead B1, that is the precardial lead. These P waves are best seen in the lead 2. Whenever you have to see the shape and the duration of the P wave, always look the P wave in the lead 2. See, this is the P wave. This is the P wave. Here it is, I have told you already that it should be less than, the duration should be less than 3 small squares, and the amplitude should be less than 2.5 squares. This is the normal P wave. This is 3 small square in width and 2.5 small squares in height. And it is always, as I told you, always positive in lead 1, lead 2 and lead 2. And always negative in AVR. This P wave is divided into three parts. The first 1/3 of the P wave denotes the right atrial activation or right atrial depolarization. And the last, that is the final 1/3, corresponds to the left atrial activation, whereas the middle 1/3 is the combination of two. I am showing this picture and showing that out of this P wave that is divided into three parts, for you to understand in the future about the possibilities of P wave abnormalities, how you have to identify the abnormal P waves. Now coming to the PR interval, it is the atrial depolarization plus delay in the AV junction. See, this is the PR interval, that is starting of the beginning of the P wave to the beginning of the QRS complex. So this is the PR interval. This is the atrial depolarization plus delay in the AV junction. This PR interval represents the time taken for the electrical impulses to travel from the atria, that is from the right atria to the ventricles, specifically from the start point of P wave to the starting point of the QRS complex. It reflects the time for the impulse to travel through the right and the left atria and the AV node. What is the normal PR interval? The normal PR interval is, this is the PR interval. The normal PR interval should be 3 to 5 small squares, that is 0.12 to 0.2 seconds. Now let us know about the QRS complex. This QRS complex represents the depolarization of both the ventricles, specifically showing that the electrical activity is associated, this QRS complex is associated with the contraction of the heart main pumping chambers. Those are they are right ventricle and the left ventricle. That is the depolarization or the contraction of the right and the left ventricle. You have to see these QRS complexes in the precordial leads. In the precordial leads from the V1, in the V1 and V2, there is a left ventricular free wall activation. This generates the S waves following initial R waves. See, this is the lead one. Initial R waves. This is the small r. Okay. As the R waves, as the precordial leads moves from V1 to V6, that is the exploring the electrodes moving laterally to the left, the R wave becomes more dominant than the S wave, and slowly the S wave becomes smaller, or sometimes it is totally lost. Here you can see in the lead one, R wave is smaller and the S wave is larger or longer. But in the lead V6, the R wave has become large and the S wave has become small. This is how the normal QRS complex looks. This is the QRS complex duration, as I told you, is less than 3 small squares, that is 0.06 to 0.1 seconds. And the Q wave amplitude, this is the Q wave amplitude, should be less than 1/3 of the QRS complex amplitude, or less than 1 small square. That is the Q wave. This Q wave in the QRS complex should be less than 1/3 of the amplitude of the R and S. That you can take it as from the R to the S. It should be less than 1/3. Whereas the S amplitude, this is the S amplitude. This S amplitude usually we have to measure in V1 and plus R amplitude in the Vy should be less than 3.5. So this amplitude of S plus R wave should be less than 3.5. In case of what it denotes, if it is increased amplitude is present, then it indicates cardiac hypertrophy. So let us now know about the ST segment. This ST segment is almost always it is flat, isoelectric. This is the ST segment. It is flat, isoelectric, and always most of the times it is in the same line as the PR interval. The PR interval. So normally it lasts for, I'll show you the duration. Normal duration of the ST segment should be less than 2 to 3 small squares, that is 80 to 120 milliseconds or 0.05 to 0.15 seconds. If I'm using the milliseconds, it is 80 to 120 milliseconds. This ST segment is always isoelectric and at the level of the PR interval. This ST segment measures the duration of plateau phase of the ventricular depolarization. It starts from the J point, that is the junction point, to the start of the T wave. We all know that T wave is the right and the left ventricular repolarization. So this ST segment is the plateau phase of the ventricular repolarization. Now let us know how the T wave looks. This T wave represents the ventricular repolarization, that is both right and the left ventricular depolarization. Normal T wave is always asymmetrical. First half having a, this is the first half having a gradual slope. I've told you, gradual slope, then the second half. This is the T wave. The first half has got a gradual slope, whereas the second half doesn't have the slope, gradual slope. It is normal. So, and coming to the amplitude of the T wave, the amplitude of the T wave rarely exceeds 10 millimeters. And it should be at least 1/8 or less than 2/3 of the amplitude of R wave. I'll show you this. See, this is the T wave. It should be less than 1/8 of the R wave, or it should be less than 2/3 of the amplitude of the R. Clear? This T wave follows the direction of the QRS complex. Normal T wave is asymmetrical, but if the T wave is symmetrical, tall or peaked or biphasic, then it is abnormal. So this is the 12 lead ECG showing the T waves. Usually the T waves are better seen in the precardial leads, that is V1, V2, V3, V4, V5 and V6. What is U wave? U wave are the small round, this is the U wave, are the small round symmetrical deflection that follows the T wave, representing the final phase of ventricular repolarization. Actually, its exact origin is still debated. Some say that it is thought to involve the late repolarization of the Purkinje fibers or other portions of the left ventricle. Still, we do not know the exact origin of the U wave. Usually, these U waves are small, round, asymmetrical, and it is always positive in the lead 2, and it is better seen in the lead 2 also with an amplitude of less than 2 millimeters. It is very, very small. Usually the U wave direction is same as the T wave. This is the positive deflection and here also positive deflection. This U wave can be seen prominently in the bradycardia, that is slow heart, when the heart rate is slow, that is in case of bradycardia. Coming to the QT interval, it is the total duration of depolarization and the repolarization of the ventricles. It represents the depolarization and repolarization, reflecting the electrical activity of the both the ventricles, right and the left ventricle. It measures from the beginning of QRS complex to the end of the T wave. QT interval usually decreases when the heart rate increases. For the normal heart rate of about 70 beats per minute, QT interval will be less than 0.4 seconds. The normal duration of QT interval, that is from the beginning of the QRS complex to the end of the T wave, it should be between 0.35 to 0.45 second. And another important aspect of the QT interval is it should not be more than half of the interval between the adjacent R waves, that is R wave, RR interval. What do you mean by this? This QT interval should not be more than half of the RR interval. It should be always less than the RR interval. This is the slide showing the PQRST complex, explaining all the waves, segments and intervals. This is P wave, QRS complex, T wave, PR segment, ST segment, PR interval, QT interval, QRS interval, and this is the J point. So this PR segment is the electrical conduction from AV node to the bundle of His, and this is the P wave is the atrial depolarization, that is both right and the left ventricular depolarization, and PR interval is the time for the electrical impulse to travel from the SA node through the AV node and entering the ventricles. And whereas the QT interval is the duration of both ventricular depolarization and the repolarization. ST segment is always isoelectric and it is in the same line of PR interval. See, here the ST segment is in the same line as the PR segment. ST segment denotes the plateau phase of repolarization, whereas the T wave represents the repolarization of both the ventricles, right and the left ventricle. Whenever you are interpreting an ECG as the normal ECG or within the normal limits, it has to fulfill the 10 ECG normal ECG rules. This 10 ECG rules is also known as the Chamberlain's 10 rules of normal. This is first invented by the Professor Chamberlain's, and hence these ECG rules are known as the Chamberlain's 10 rules of normal. Let us know one by one what these normal rules suggest. Rule 1. This PR interval should be 120 to 200 milliseconds or should be between 3 to 5 small squares. Here they have mentioned in the milliseconds. In terms of seconds, it will be 0.12 to 0.2 seconds. Rule 2. In the rule 2 suggests that the QRS complex, width of the QRS complex should not exceed 110 milliseconds. That is, should not exceed 3 small squares. Rule 3 is the QRS complex should be dominantly upright in the lead 1 and lead 2. Here, see, these QRS complexes are dominantly upright. Coming to the rule 4, the QRS complex and the T waves tends to have the same general direction in the limb leads. That is, in the same direction. That is the upward direction only it should be present. In the AVR, all the leads are in the negative direction. What this rule 5 suggests? In the lead AVR, all the waves should be negative. P wave, QRS complex and the T wave, all the waves and the segments, everything are in negative deflection in the lead AVR. This rule 6 suggests that this R wave must grow. That is, the duration of the R wave, that is, the amplitude of the R wave should increase from V1 to should increase in the amplitude from V1 to V6, V4 or V6. Whereas the S wave must grow from V1 to at least V3, but later it should go on decrease in its amplitude and sometimes it may disappear in the V6 also. That is the normal ECG pattern of the R wave and the S wave. Coming to the rule 7, this ST segment, that is between the end of the QRS complex and the beginning of the T wave, should be isoelectric except V1 and V2 where it may be elevated. So, whenever the ST segment is elevated in the lead V1 and V2, there won't be any problem. That doesn't denote it is abnormal ST segment. It is a normal feature of ST segment elevated in the V1 and V2. Coming to rule 8, This P wave should be upright in lead 1, lead 2 and V2, V3, V4, V5 and V6. This is very important. This P wave beginning of the PQRS complex, this P wave which denotes the atrial depolarization should be upright in the lead 1, lead 2 and V2 to P6. Coming to the rule 9, there should be no Q wave or only a small Q wave less than 0.04 seconds in width in lead 1, lead 2 and V2 to V6. Rule 10 says that the T wave must be upright, that is with the positive deflection in lead 1, lead 1, lead 2 and from lead V1, V2, V3, V4, V5 and V6. If the T wave is inverted in lead 3 or V1, it is not abnormal. Only when it is abnormal, when the T wave is negative in lead V1, lead 1, lead 2 and V2 to V6. I am ending the session with the normal ECG wave for ECG showing its waveforms and the intervals. I hope you people have understood the basics of ECG and how to interpret a normal ECG and what are the factors you have to interpret in an orderly manner, how to identify the normal waveforms and the intervals, and what are the how to calculate the duration of the waves and the intervals. Now the session is open for discussion. Any questions? If you have any doubts or clarification, please raise your hand so that I will be in a position to answer your doubts and clarify your doubts. No doubts? Yeah,
Okay, unmute ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ಟೆ.
you can unmute so that you can, I'm audible to your questions.
Ma'am, some doctor wants to know rule number 9 and 10.
Okay, you want me to repeat?
Yes, ma'am.
See, in the rule 9, normally in the ECG, there won't be any Q waves. And very small Q waves of less than 0. See, here you can't see, here is very small, very negligible. In the lead 1, you can't see. In the lead 1 and lead 2, you can see very small, that is less than 0.04 seconds. That is here this is the time speed of the speed calibration. That is the x-axis denotes the speed in seconds. So here this vertical axis denotes the amplitude. So it should not be more than 0.4 seconds in width in lead 1, 2 and V2, V3, V4, V5 and V6. You can see here the Q waves. See, Q waves is not at all seen in V4. It is also not seen here. Here you can see a small Q wave. Very small. This is the R wave. This is the Q wave. Beginning of the QRS complex. Here you can see the Q wave. See, this is the Q wave. It is normal, but it is not present in the lead 3. In the normal ECG, it won't be there. When the Q wave is present prominently, you can visualize the Q wave. It denotes the abnormal ECG. Coming to the rule 10, the T wave in the leads, standard ECG leads, must be always upright in the lead 1, lead 2 and V2 to V6. That is V2, V3, V5, V4, V5 and V6. You can see the T wave in the upright direction. I hope people have understood. One more person has asked about what is the significance of PR interval. This is the PR interval. Starting of the P wave to the starting of the QRS complex. That is the duration between the start of the P wave to the beginning of the QRS complex. It includes atrial depolarization plus delay in the AV junction. This signifies that it is the time taken for the electrical impulses. I'll show you the conduction system so that you can understand better. This is the conduction system of the heart. So this PR interval represents the time taken by the electrical impulse or the cardiac impulse to travel from the SA node, that is from the atria of the both the through the internodal pathways to reach the AV node. That is the ventricles to AV node, so that the impulses are transmitted from the atria to the AV node, so that the further activation of the ventricles, that is the QRS complex, which denotes the ventricular depolarization, can start. One more person has asked about how the sweating becomes an indication of ECG. Why it is necessary? See, sweating, it can occur normally also, but when the sweating occurs is more important when you are lying down, when you are taking the rest, and when you are climbing the upstairs, that is upright direction. If you sweat more, that means when the heart rate increases, then there must be some underlying cardiac pathology could be there. So it's better you have to go for one ECG testing, especially if the patients are having comorbidities like diabetes and hypertension. It is always indicated When you sweat more, especially during the night times, ECG, you have to undergo one ECG investigation.
Okay, ma'am. If any one having doubts, let
One
them
more
put
person
in the
has asked about the P wave. I'll explain you in detail. Okay.
Hmm.
Yes. See, this is the normal P wave, how it looks in the normal ECG. It is always positive in lead 1 and lead 2. And somebody has asked, what is it?
Here interval above 5 mm and 5 months in months. Heart denotes here.
That. See, somebody has asked if the PR interval is more than the 5 small squares, what it denotes. See, this normally the PR interval should be within 3 to 5 small squares or 0.12 to 0.2 seconds. It is prolonged in the first degree AB block. This abnormal PR interval or P wave or any wave and the interval, tomorrow I'll be explaining in detail about the how the PR interval duration represents the underlying causes, underlying cardiac problems like first degree block, second degree block, and the complete heart block. Okay. So today you just know what is the normal duration. If it increases, what will happen? If it becomes smaller, what will happen? Okay. In the short PR, if there is short PR interval, it denotes WPW syndrome. If it is long PR, I've just mentioned here. That's all. Tomorrow, I'll be explaining you in detail about the abnormal intervals, abnormal waves, abnormal QRS complex, abnormal axis, abnormal T waves, everything in detail. Okay. Any
Okay, ma'am.
question?
If anyone is having any doubt, let them put in the group. We'll answer tomorrow, ma'am.
Okay. Any doubts?
We'll wind up the class, ma'am.
Yeah. Hope you people have understood.
Yes, ma'am. Thank you, ma'am.
Thank you.
Yes, ma'am.
Thank you very much to all the doctors. Thank you very much. And we request you to join tomorrow by the same 7 p.m.
Thank you.
Thank
Anil sir, tomorrow please make it PPT mode. Today it was very small. Below you just press it, it will convert to the PPT mode. Then it will be easy for everyone to
So
see.
you people can increase the size, no?
The problem is here, if we make it PPT mode, the cursor has some problems, sir. That's why we requested the participant to zoom out their screen.
Fine, fine, sir. Tomorrow we'll try to
Yeah, we'll try to sort
solve
out.
it out. Yes, yes. Sir.
Thank you.
Thank you all.
Thank you, ma'am. Thank you, ma'am.
Okay, thank you, ma'am.
Night all.
Thank you.